Hi everyone. Welcome to you all to our pediatrics university question and answer essay discussion. So, in the last video, we were discussed about the micronutrients and their deficiency disorders. We were discussed about the vitamin A and its deficiency disorder. Then we talked about the vitamin C and its deficiency disorder scurvy, and also talked about the vitamin K, that is hemorrhagic disease of newborn. So in this video, we will discuss about the other vitamins, that is vitamin D, and then niacin deficiency, and also other minerals like zinc deficiency and the iodine deficiency. Okay. So these are the most importantly asked in our university exams. These are the questions. And coming to the vitamin D, they usually ask the university questions are what are the radiological features of nutritional requests, draw and label, then clinical and radiological findings in rickets, then biochemical changes in rickets, then clinical features of rickets in the infancy, radiological response to vitamin D treatment in the rickets, then causes of delayed dentition, treatment of the nutritional rickets, vitamin D resistant rickets, non-nutritional rickets, and so these are the important questions which are usually asked in our university exam. So let's start our discussion. Okay, the vitamin D that is most importantly important for our university exam. So listen. So first, vitamin D, which comprises a family of fat-soluble vitamins. We already taught that vitamin D is a fat-soluble vitamin, and hormones that, when deficient in diet, causes rickets from defective mineralization of the growing bone and osteomalacia in the non-growing bone. So these are the this is a introduction for the vitamin D. So it is a fat soluble vitamin, and it is also act as a hormone. And when it is deficient in the diet, that causes rickets in the children's. That is defective mineralization of the bone in the children's, and also there will be osteomalacia, that is softening of the bone in the adult bone. So the sources of the vitamin D include the facultative vitamin is required from the diet only. When insufficient, vitamin D3 is made from the 7-dehydrocholesterol in the skin by the irradiation with the UV light. And whole body sun exposure for the 30 minutes per week, or head exposure for the 2 hours per week to synthesis of the 10 microgram of the vitamin D. And dark skinned people need much more sunlight exposure to synthesize the same vitamin D as compared to whites. And what are the sources of the important sources of the vitamin D? The fish, liver, and oils are the good sources for the vitamin D. And the human milk, which contains only 30 to 40 international units per liter. And the recommended daily allowance for the vitamin D is 400 international units per day. And this is most commonly asked as a 1 mark question, that is recommended daily allowance for the vitamin D is 400 international units per day. And then coming to the vitamin D metabolism and functions, that is how it metabolized in our body and what are the functions that is maintained by the vitamin D. Usually, we already told that it is derived from the 7-dehydrocholesterol by the radiation with the UV radiation in the sunlight that causes the production of the vitamin D3. And this vitamin D3 binds with the vitamin D binding proteins and transported to the liver, and the 25 hydroxylase enzyme is present that causes the hydroxylation of the vitamin D3 that produces 25 hydroxy vitamin D3, and this again transported to kidney, and there an enzyme present that is called the 1-alpha hydroxylase, and that again causes hydroxylation of the 25 D, and that causes the 125 dihydroxycholecalciferol. And these binds to, and this 125, that is also called the that is act as a hormone. It binds to intracellular receptor, and which forms a complex, and that mediate these functions, like that increases the calcium absorption and from the intestine, and also which causes the increased phosphorus reabsorption from the renal tubules, and also which causes the increased bone resorption, and which also causes the decreased PTH secretion and inhibits its own synthesis in the kidney. So these are the functions of the vitamin D in our body. And the functions these are the functions again: intestine, which increases the reabsorption of the calcium; in the kidney, it increases the calcium reabsorption in the tubule; and in the bone, which causes mineralization over osteo tissue by remodeling the bone with increased osteoclastic activity, that causes, that is, increased bone resorption by activating the osteoclastic activity. Then 125 dihydroxy calciferol is the most biologically active vitamin D metabolite involved in maintaining the calcium and phosphate homeostasis. Then, what are the actions of vitamin D in other tissues? In other tissues, this is the major actions, that is increased calcium absorption, increased phosphorus reabsorption of the tubules, increased bone resorption by the activating the osteoclast, and decreased PTH secretion inhibits its own synthesis in the kidney. And other actions in the other tissues are stimulation of the insulin secretion from the pancreas and prolactin from the pituitary. And another is the inhibiting action is on the renin secretion from the kidney. There have a inhibiting action of the vitamin D. Atrial natriuretic peptide from the heart is also, there will be inhibiting action on the release of this atrial natriuretic peptide. And in the breast, colon, and prostate cancer cell progression, there will be inhibitory effect on by vitamin D. Then calcitriol, which enables the innate immune system by inducing antimicrobial peptides such as cathepsin. Then myocardial contractility and vascular tone, which are also modulated by the calcitriol. The treatment and prevention of the pneumonia, we can use the vitamin D. So these are the other actions of the vitamin D, both stimulatory actions and inhibitory actions. Then moving on to the main topic, that is vitamin D deficiency rickets. It is most commonly asked in the university exam. The clinical and the radiological findings of rickets, and what is the refractory rickets, non-nutrition rickets. So this is an important um, topic. So first we will start with the vitamin D deficiency and rickets. So first we have the definition. ഏതൊരു എഴുതുന്നതിന് മുമ്പ് ഡെഫിനിഷൻ, etiology, clinical features, laboratory findings, management, ഇതാണ് order. അപ്പം first is the definition. Definition of the rickets, which include generalized metabolic bone disorder that is characterized by the failure or delayed mineralization of the growing bone, which occurring in the children before the fusion of the epiphysis. And if the delayed mineralization of growing bone, the delayed mineralization of the bone which happening after the fusion of the epiphysis in the adult, that is called the osteomalacia, that is softening of the bone. Here, that is occurring, that is before the fusion of the epiphysis in the children, there will be delayed mineralization of growing bone. That is results in the rickets. And this is only the defect in the mineralization of the bone. Okay, this is the important delay or the failure or the delayed mineralization of the growing bone which occur in children before the fusion of the epiphysis. This is the definition of the vitamin D deficiency, that is rickets. Then rickets, which can be classified into calcipenic, that is inability to maintain the calcium, and hypophosphatemic, that is altered phosphate. Then the calcipenic, which can be divided into vitamin D deficiency and non-nutritional. The vitamin D deficiency is due to nutritional deficiency, prematurity, maternal deficiency of the vitamin D, malabsorption. These are the vitamin D deficiency, calcipenic rickets. Then non-nutritional cause of calcipenic rickets is the vitamin D dependent rickets type 1, vitamin D dependent rickets type 2. Then we have the hypophosphatemic rickets. In that we have the vitamin D resistant rickets. There are different types, that is X-linked hypophosphatemic rickets, autosomal dominant hypophosphatemic rickets, hereditary hypophosphatemic rickets with the hypercalciuria, and the renal tubular acidosis. These are the causes of the vitamin D resistance. That is the because of this altered phosphate level, we have the rickets. That is due to vitamin D resistant rickets. And because of the inability to maintain the calcium, that is calcipenic rickets. These are the causes for the calcipenic rickets. So these are the etiological classification of the rickets: calcipenic and hypophosphatemic. It's not hyper, it's hypophosphatemic. Okay. Then the nutritional vitamin D deficiency, which remains the most common cause of the ricket globally. Non-nutritional rickets are there, but the nutritional vitamin D deficiencies, which remains the most common cause of the rickets. Then vitamin D dependent rickets type 1, where they have alpha hydroxylase deficiency, so decreased to 125 dihydroxy vitamin D3. In the VDTR type 2, that is in the type 2 vitamin D dependent rickets, there is decreased receptor activity of the 125 dihydroxy vitamin D3 that is associated with alopecia. So in the case of the non-nutritional rickets of the calcipenic variety, we have the vitamin D dependent rickets type 1 and type 2. In the type 2, there will be deficiency of this enzyme, but in the type 2, there will be decreased receptor activity. This should be kept in mind. By type 1 is due to 1-alpha hydroxylase deficiency, and the type 2 is due to there will be no deficiency of an enzyme, but it is due to decreased receptor activity to 125 dihydroxy vitamin D3. Then what are the clinical features of the rickets? These are the important question which is usually asked in our university exam. What are the clinical features of rickets? So rickets which develops in those children in whom dietary calcium deficiency is superimposed on low baseline vitamin D status. And the age of onset usually between the 6 months and 2 years of age, and which may present early, that is 3 to 6 months of age. It can also present as early in the 3 to 6 months of age. And the clinical features which depends upon the age and severity of the disease. That is, depending upon the age, that is in the clinical features which varies. So these are follows. That is, in the newborn and young infants, it is present as hypocalcemic seizures, and in the late infancy and the childhood, which present as the general features like a failure to thrive, that is inadequate weight gain as compared to the same age and sex peer groups. Then protruding abdomen, muscle weakness, especially proximal muscle weakness, and fractures. These are the general features in the late infancy and childhood. Head, we have the craniotypes. That is, craniotypes, which means because of the softening, there will be ping pong ball mechanism is there. That is called the craniotypes. First clinical sign of the active rickets is the craniotypes. Then we have the frontal posing, delayed fontanel closure, delayed dentition, and the caries and craniosynostosis. These are the head features, and the chest features are the rachitic rosary because of the prominence, because of the swelling of the costochondral junction. There will be prominence of the beading of the anterior chest wall. That is called the rachitic rosary. And that then will have the Harrison's groove. There will be depression at the attachment of the diaphragm to the chest wall. That is called the Harrison's groove. And we have the respiratory infections and atelectasis. These are the chest features. And the back, in the back, we have the scoliosis, kyphosis, and lordosis because of the structural bony abnormalities. Then at the extremities, we have the features like enlargement of the wrist and ankles because of the hypertrophy of the chondrocytes on the growth plates. We have the enlargement of the wrist and ankle. Then we have the vagus and valgus deformity because of the increased weight bearing on the soft bones. Then we have the wine swept deformity, that is combination of the valgus deformity of the one leg with the varus deformity. The other leg is called the wind swept deformity. Then we have the anterior bobbing of the TP and the femur, coxa vara, leg pain, and double medial malleolus because of the hypertrophy of uh, the chondrocytes on the growth plate. We have the double medial malleolus instead of the single. Then in the spine, we have the scoliosis, kyphotic deformity, and we have the more commonly proximal muscle weakness, and we have also the delayed motor milestones will be there in the late infancy and childhood. Then we have the abdomen, we have the viscera of ptosis and protuberant abdomen, and in the respiratory, we have the recurrent pneumonia and hypocalcemic symptoms, tetany, seizures, and stridor due to the laryngeal spasm. So these are the important features in the late infancy and childhood. As നമുക്ക് ഓർത്ത് വെക്കാൻ വേണ്ടിയിട്ട് general features and the head, from head to toe, we can remember head, in the teeth, in the chest, back, extremities, spine, abdomen, and we have these features in the late infancy and childhood. Then in the adolescent, the patients have present with the muscle cramps and tetany because of the hypocalcemia. And so these are the features of the diagrammatic representation of the features of the rickets. So the 10 important clinical features in the rickets, which are the from head to toe, we have the delayed closure of the fontanelles, craniotypes, that is ping pong ball mechanism, then white sutures. Then we have the frontal posing, then dental hypoplasia, and in the chest we have the rachitic rosary, that is prominence of the costochondral junction. Then pectus carinatum, that is the protrusion of the manubrium sternum, that is pectus carinatum. Then we have the Harrison sulcus. Then that is there is a depression in the attachment of the diaphragm to the chest wall, that is Harrison sulcus. Then we have in the leg we have or the wrist, we have the swelling in the wrist and ankle joints, and there will be bowing of the legs because of the weight bearing. There will be because of the decreased mineralization, the leg will be bows. That is called the bowing of the legs. And so these are the 10 important clinical features in the rickets from the head to bottom. Then this is the rachitic rosary. In this picture, there will be a rachitic rosary. That is because of the prominence or because of the hypertrophy of the chondrocytes on the growth plates. There will be prominence of the costochondral junction. There will be beading on the anterior chest wall. That is called the rachitic rosary. Okay, so then how will you diagnose the case of the rickets? Radiologically, most commonly radiologically, we can diagnose the uh, uh, rickets, and also we can diagnosed by the biochemical analysis. And the first and foremost is the radiological, that is AP view of the wrist is the best, shows the radiological change in the rickets, though it can also be seen at other growth plates also. There will be decreased calcification leads to thickening of the growth plate, fraying, flaring, and cupping of the epiphysis. These should be kept in mind. What are the radiological features of the rickets? There will be fraying, flaring, and cupping. Fraying, flaring, and cupping of the epiphysis. And fraying is called the irregular calcium deposit which occurs at the edge of the metaphysis, and it loses its sharp border. It's specific for the rickets. So fraying is specific for the rickets. Then we have the coarse trabeculation of the diaphysis and generalized rarefaction. So fraying, flaring, and cupping and widening of the bones are the features of the rickets, radiological features of the rickets. There's a widening of the sutures of the skull epiphysis, periosteal reaction, pollex, knock knees, triradiate pelvis, scoliosis. The healing process is characterized by the broadened bands of increased density, zone of fluorescence calcification. These are the radiological features of the uh, rickets. Then we have the biochemistry. In the biochemistry, there will be decreased 25 hydroxy D3 level, which confirms the deficiency rickets, and associated biochemical findings are normal or decreased serum calcium, low serum phosphorus, and serum alkaline phosphatase, which increases. So these are the biochemical analysis value, which is suggestive of the rickets, and these are the radiological factors. So radiologically and biochemically, we can confirm the diagnosis of the rickets. Then how will you treat the Mm, vitamin D deficiency? The STORES regimen, that is 6 lakhs international unit single dose oral or the intramuscularly, and or oral calcium supplements 50 to 75 milligram per kilogram per day for the 3 to 6 months. And alternative regimen is daily vitamin D oral or intramuscular 1000 to 5000 international unit per day for the 4 to 6 weeks, followed by the oral calcium supplements 50 to 75 milligram per kilogram per day 3 to 6 months. That is, along with the vitamin D, we have to supplement the oral calcium also in the dose of 50 to 75 milligram per kilogram per day for the 3 to 6 months. And continue the maintaining dose of the 400 national unit of vitamin D and calcium 500 milligram per day. Then, so that is all regarding the treatment of the vitamin D. And the response to treatment, this is also a question which is asked in our university exam. The patient with the vitamin D deficiency can show the evidence of the radiological healing within 4 weeks of treatment. So after treatment with the vitamin D, after 4 weeks, there will be a radiological evidence of healing. And there is also the biochemical improvement which precedes radiological improvement. And the calcium, phosphorus, and parathyroid hormone concentration should normalize within 1 to 3 weeks. And the third response to treatment is radiological evidence of improvement, which occurs in 2 to 4 weeks of treatment. There will be Harris line, thin radiodense lines due to the growth arrest in the metaphysis. Parallel to growth plate will be there. Then calcification of the osteo tissue and increase in the length of the bones. And if the failure to respond to 2 doses of vitamin D for weeks apart should prompt search for the non-nutritional rickets or the refractory rickets. So these are the response of treatment. That is the radiological healing within 4 weeks of treatment and biochemical improvement which precedes by radiological improvement. Calcium, phosphorus, and parathyroid hormone concentration should normalize within 1 to 3 weeks because of the treatment with vitamin D. And also there will be the Harris line, calcification of osteo tissue and increase in the length of the bone. These are the response of treatment of the nutritional deficient rickets. Okay. Then we have the non-nutritional rickets. The non-nutritional rickets is not due to the vitamin or nutritional deficiency. It is due to some other causes. That is, there are two types of the non-nutritional rickets: vitamin D dependent rickets and vitamin D resistant rickets. In the vitamin D dependent rickets, it is also known as a pseudo vitamin D deficiency rickets. There are two types of the vitamin D dependent rickets, that is type 1 and type 2, which occurs despite adequate intake of the vitamin D. That is, we consumes adequate amount of the vitamin D. In spite of that, also we can get the rickets. That is called the uh, vitamin D dependent rickets. And features or biochemical changes which are similar to nutritional rickets. but it is not due to the nutritional deficiency. But do not respond to physiological dose of vitamin D, which requires a large doses for the lifelong. That is, this vitamin D dependent rickets, which behaves like the nutritional rickets, but it's not due to any nutritional deficiency. It do not respond to physiological dose of the vitamin D, which is usually be given in the case of treatment. It requires large doses for the for a lifetime period. And this is the classification. This is the table which showing the difference between the type 1 and type 2. In the type 1, there will be, as we already taught that it is a deficiency, the 1-alpha hydroxylase deficiency. Here there is a receptor resistance and it's end organ resistance to the vitamin D. In the type 1, it is an autosomal recessive, and type 2 is also an autosomal recessive. It is due to 1-alpha hydroxylase deficiency that converts calcidiol to calcitriol in the kidney. So there will be accumulation of calcidiol, and in the VDDR type 2, there will be, this is also an autosomal recessive. But here it is an abnormality in the calcidiol receptor causing an end organ resistance to vitamin D. It is not due to any enzyme deficiency. And the clinical features, type 1, which is have an early onset rickets, 3 to 6 months, and it is a severe rickets. In the type 2, it is also a severe rickets, and it present as short stature and alopecia in the 50 to 70% of cases. And how will you investigate each type? In the type 1 cases, we have to investigate for the calcium level. So there will be hypocalcemia and acidosis due to the renal tubular dysfunction. And also there will be low 125 dihydroxycholecalciferol. And the type 2, there will be low calcium, raised alkaline phosphatase, and increased 125 hydroxy vitamin D3. So to differentiate between, in the type 1, there will be low 125 dihydroxycholecalciferol, but in the case of the type 2, there will be increased 125 dihydroxy vitamin D3 because of the end organ resistance in the case of type 2. And what is the treatment for the each type? That is, in the type 1, we have to supplement the calcitriol or the vitamin D active form 0.5 to 2 microgram per day. And in the type 2, we have these patients which are resistant to treatment. That is, these patients, the type 2 patients which are resistant to the treatment because of the end organ resistance. Some which may respond to high doses of vitamin D due to the partially functioning receptors. And 3 to 6 months trial given to all the patients with high doses of vitamin D. And the vitamin D2, we have to give the 2 lakhs international unit, and vitamin D3, we have to give 50 to 60 microgram per day plus long-term oral the IV calcium. This is the treatment for the type 2. Then next non-nutritional rickets is the vitamin D resistant rickets, which means there is no response to usual treatment of the vitamin D. So classification is hereditary rickets of renal origin and oncogenic rickets. So in the hereditary, we have 4 types. That is, uh, everything is hyperphosphatemic, or commented everything is hyperphosphatemic, and the first word is only changed. It is primary, idiopathic, autosomal recessive, autosomal dominant, hyperphosphatemic rickets. And the rickets of renal origin are classified into glomerular rickets, that is due to renal, and tubular rickets, that is in that renal tubular acidosis and Fanconi syndrome, which contributes to tubular rickets. And also we have the oncogenic rickets. So these are the 3 classification of the vitamin D resistant rickets: hereditary, rickets of renal origin, and oncogenic. In the hereditary, we have the 4 types: primary, idiopathic, autosomal recessive, and autosomal dominant hypophosphatemic rickets. And we have the rickets of renal origin, which contains glomerular rickets and tubular rickets. And we have the oncogenic rickets. So these are the table which showing different vitamin D resistant rickets. First one is the X-linked hypophosphatemia rickets. The defect is it is an X-linked dominant disorder which defects in the proximal tubular reabsorption of phosphates and conversion of the 25 hydroxy vitamin D3 to 125 dihydroxycholecalciferol. And the clinical features, that is the child which presents at the age of 6 months to 5 years of age and is present as short stature and limb deformity, that is a battling gait will be there, and bobbing of the lower limbs, coxa vara or the genu varum or the genu valgum will be there, and delayed dentition and pulp defect. These are the clinical features when a child with the X-linked hypophosphatemia rickets presents. And investigation, we have to look for the serum calcium, which is normal. Serum phosphate is also decreased, and the serum alkaline phosphatase and the parathyroid hormone, which are normal. Urine, there will be phosphaturia because of the defect in the proximal tubular reabsorption of phosphates. Then treatment, we have to supplement the oral phosphate 0.52 because these are the vitamin D resistant rickets. So, in the supplementation of the vitamin D have the no important role, but we have to supplement the oral phosphate because it is due to hypophosphatemia. We have to supplement oral phosphate 0.5 to 1 gram per day in the infants and to 1 to 4 gram per day for the older children. And it is given in the 4 to 6 divided doses. Most common side effect is the diarrhea. So, and also we have to supplement the calcitriol 30 to 70 nanogram per kilogram per day in 2 divided doses. And we have to give amiloride and hydrochlorothiazide to prevent the nephrocalcinosis. Then next one is the idiopathic, that is the vitamin D resistant rickets. We have the another is hereditary. We have the another is idiopathic hyperphosphatemia rickets, that is defective renal tubular absorption of the phosphates. In the clinical features are hyperabsorption of calcium. Therefore, there will be hypercalciuria will be there. And investigation, there will be normal serum calcium level, low serum phosphate levels, and high 125 dihydroxycholic acid. And the treatment is with the oral phosphate, amiloride, and hydrochlorothiazide. Then at the next one is autosomal recessive hypophosphatemia rickets. That is it is an autosomal recessive condition that is due to the increased urinary excretion of the phosphates by the kidneys despite low phosphorus in the blood. And the clinical features, it present with the nephrocalcinosis, and investigation is that will shows the normal serum calcium and low serum phosphates and raised serum alkaline phosphatase and high 125 dihydroxycholic acid overall. And the treatment is we have to supplement the oral phosphate and diuretics for the nephrocalcinosis. The next one is the autosomal dominant hypophosphatemia rickets. That is an autosomal dominant disorder, that is increased renal phosphate wasting with the normal calcitriol. Clinical features, they present with the lower limb deformity and bone pain. The investigations are low phosphate level, normal 125 dihydroxycholic acid overall. And the treatment is we have to supplement the oral phosphate and calcitriol. And next is the renal rickets. In that we have the glomerular rickets and the tubular rickets. In the glomerular rickets, there will be inability to convert 25 hydroxy vitamin D to 125 dihydroxy vitamin D, and there will be impaired glomerular filtration will lead to urea and phosphate retention that results in the lowering of the serum calcium. The clinical features of the underlying disorder, that is galactosemia, Lowe syndrome, and Wilson disease will be there. And investigations of underlying disorder should be done. And the treatment, it is treat primary cause of the renal failure. That is, the glomerular or the renal rickets is due to the renal failure. So we have to treat the primary cause of the renal failure, and we have to supplement the high dose of the vitamin D. And the tubular rickets, the proximal renal tubular tubular acidosis. We have posturia, distal renal tubular acidosis. We have the bone demineralization without overt rickets. And clinical features, we have to look for the clinical features of the underlying disorder. And investigation also, we have to look for the investigation to rule out the underlying disorder. And the treatment, we have treatment for the renal tubular acidosis. And then we have the next category is oncogenic rickets. We have the soft tissue of the bone tumor secrete phosphatonin, which impairs tubular reabsorption of phosphate. That is because of that, we'll have the rickets. Then the clinical features of underlying tumors, the tumors of the mesenchymal origin, neurofibromatosis, etc. And in investigation, we have the in the serum we have the low phosphate levels, the normal calcium and calcitriol level, and the treatment is we have to resect the tumor. That is tumor which causes the rickets because of the secretion of the phosphatonin, which impairs tubular reabsorption of phosphate. So we have to resect the tumor, and we have to supplement the vitamin D3 and oral phosphate. So these are the non vitamin D resistant rickets. So these are the vitamin D resistant rickets, class of a type of the non-nutritional rickets. So then I will be showing a PDF is showing how will you approach a case of the refractory rickets. That is from the new edition. That is from the new edition OP guide. So this is the the approach of the towards the refractory rickets, we have to first look for the serum phosphate, and if the serum phosphate is high, that is indicative of the chronic kidney disease that contributes to refractory rickets. And if the serum phosphate is low or normal, we have to look for the blood pH. And if the blood pH is low, that is which means acidosis, that is indicative of the renal tubular acidosis. And if the blood pH is normal, we have to look for the serum parathyroid hormone levels and calcium levels. By doing that, if we get a high parathyroid hormone or low or normal calcium levels, that is indicative of the vitamin D dependent rickets. And if we're doing the parathyroid hormone calcium, that will be normal PTH and normal calcium. That will be indicative of the hyperphosphatemic rickets. Okay. So this is the biochemical evaluation of child with refractory rickets. We can identify what are the causes for the refractory rickets. Okay. Then the pointers to non-nutritional rickets, that is both vitamin D dependent rickets and vitamin resistant rickets. There will be some pointers to non-nutritional rickets. That is history of the polyuria will be there, polydipsia, preference for the savory foods, marked stunting, undernutrition will be there, onset in the early infancy. This is the most important. The non-nutritional rickets which have the early onset. Early infancy onset will be there. Then we alopecia, epidermal cyst and milia will be there. Alopecia is most important. And history of the tetany and seizures, this is most important. Family history of the rickets. And because most of the is due to hereditary and non-response standard treatment of rickets. This is the most important pointer towards the non-nutritional rickets. That is no response to standard treatment of rickets. And also there will be normal levels of the 25-hydroxycholic acid. So these are the pointers, important pointers towards the non-operational rickets. So this is the picture showing the nutritional rickets. That is the rickets, radiological features for rickets. There will be fraying, cupping, and there will be widening of the joints because of the hypertrophy of the chondrocytes. And this is also there will be widening, there will be fraying, cupping. That is the regular bone, irregular metaphysis fraying. That is this is cupping. So these are the radiological features. Then this is the treatment guidelines of the nutritional rickets. We have to learn the treatment for the nutrition requirements from this OP guide new edition. So this is also, this is the when the according to age, the treatment guidelines is written. That is less than 6 months, we have to give a daily dose of vitamin D for 12 weeks. Now it is for the 12 weeks, we have to give 2000 inhalation unit, and alternative intermittent dose regimen is not recommended in the less than 6 months old age. And the daily calcium supplementation is, we have to give along with the vitamin D3, we have to give the daily calcium supplementation 30 to 75 milligram per kilogram. It is similar in all the age groups. And daily maintenance dose we have to give in the less than 6 months and 6 to 12 months, we have to give 400 international unit. And in the 6 to 12 months of age, we have again give the daily dose of vitamin D3 for 12 weeks, 2000 international unit. And alternative intermittent dose regimen is equivalent to 2000 international unit per day, which may be given on a weekly or monthly basis. Also, daily calcium and daily maintenance dose is similar to those of less than 6 months year old child. Then greater than 12 months of age, we have to give the 3000 international unit as daily dose of vitamin D3 for the 12 weeks. So they should be for the 12 weeks, we have to give a low dose, that is 3000 international unit. And alternative intermittent dose regimen is we have to give 60,000 international unit every 2 weeks for the 5 doses. Then daily calcium 30 to 60, 30 to 75 milligram per kilogram per day. And we have to give the daily maintenance dose of increased amount, that is 600 international unit. So this is the treatment guidelines and nutrition requirements as per the new OP guide. So that's all about the vitamin D deficiency and the rickets disorders. And then I'm already told that the osteomalacia is due that is bone demineralization after the fusion of the bones or the epiphysis. And the osteomalacia usually occurs in the adulthood, and the osteomalacia should be differentiated from the osteoporosis, that in the osteomalacia there will be only defective mineralization, but in the case of the osteoporosis there will be both organic and mineral mineralization of the bone is not happen. That is, both there will be um, decrease in the bone density. That is in the case of the osteoporosis, and is due to any prolonged corticosteroid therapy. So that should be differentiated from the osteomalacia. Osteomalacia, which means as the name indicates, that is the softening of the bone. So this is the diagram which showing the diagrammatic representation of rickets. That is, there will be widening of the metaphysis because of the defective apoptosis of the chondrocytes because of the lack of phosphates in the rickets. Usually there will be a zone of the provisional zone of calcification, and there will be a growth plate at the between the metaphysis and epiphysis. And this growth plate, we have the that is the pathophysiology behind the rickets is that there will be a growth plate between the metaphysis and epiphysis, and in the growth plate we have the numerous number of the chondrocytes will be there, and these chondrocytes in the presence of the phosphate that undergo the apoptosis, and there will be invasion of the new bond forming cells, and there will be formation of the new bonds. But in the case of the rickets, there will be deficiency of the phosphate will be there. So because of the deficiency of phosphate, there will be defective apoptosis that results in the hypertrophy of the chondrocyte, that results in the widening. There will be hypertrophy of the chondrocytes in the growth plate that causes the widening of the growth plate, and also there will be cupping with the fraying. That is a regular bond margin, metaphyseal margin is called the cupping with the fraying, and also there will be zone of the preparatory calcification is there. So these are all about the vitamin D deficiency disorders. Then we go into the niacin deficiency. Okay. So in the niacin deficiency, niacin is also known as the vitamin B3. Nicotinic acid and nicotinamide, biologically equivalent to vitamins, are both referred to as the niacin. The niacin, that is a part of the NAD and NADP, that is a coenzymes in the oxidation reduction reactions and cellular respiration. And the most common sources of the niacin or the vitamin B3 is milk, egg, meat, legumes, peanuts are good source of niacin. Deficiency occurs in areas where the maize is the staple food, as niacin in the maize is present in the bond form and not easily absorbed by the body. The vitamin is resistant to heating. The niacin, which can be synthesized in the body from the tryptophan, however, the conversion ratio is 60:1, requiring large amount of the tryptophan to meet the niacin needs. So if there is any deficiency of tryptophan, also there will be concomitant niacin deficiency will be there. And then the niacin deficiency leads to pellagra, that which is characterized by 3 Ds, that is dermatitis, diarrhea, and dementia. These are the 3 Ds that is the characteristic feature of the pellagra, that is dermatitis, diarrhea, and dementia. 3 Ds, dermatitis, diarrhea, and dementia. The cutaneous lesions, which consist of the symmetrical pigmented rash in the body parts, which is exposed to sunlight, especially in the neck. That is, sunlight exposure ചെയ്യുന്ന ഏരിയയിൽ കൂടുതലായിട്ട് അവിടെ നമുക്ക് ഡെർമറ്റൈറ്റിസ് ഓർ ക്യൂട്ടേനിയസ് ലേഷൻസ് കാണാൻ പറ്റും. ഒരു ഇപ്പോൾ കാസൽസ് നെക്ലേസ് ഓർ ബാക്കിലൊക്കെ നമുക്കൊരു ഡെർമറ്റൈറ്റിസ് പോലത്തെ ലേഷൻ കാണാൻ പറ്റും. ആൻഡ് ദ ഡയഗ്നോസിസ് ഇസ് സസ്പെക്ടഡ് ഓൺ ദ ഹിസ്റ്ററി ഓഫ് ദി ഇനാഡിക്വേറ്റ് ഡയറ്റ് ഓർ ക്രോണിക് ആൽക്കഹോൾ ഇൻജെക്ഷൻ വിത്ത് ദ ടിപ്പിക്കൽ ക്ലിനിക്കൽ ഫീച്ചേഴ്സ് ലൈക്ക് these cutaneous lesions are the hallmark for the pellagra, that is a castle necklace, or the back there will be that sun exposed area, there will be cutaneous lesions. And the treatment of the pellagra, which include the daily dose for the treatment, is about 10 times the recommended dietary intake, that is 50 to 300 milligram per day. So that is all about the niacin deficiency. Then another mineral is the zinc. That is, it is an essential trace element. Zinc is an essential trace element. The zinc deficiency disorder is also an important zinc deficiency in children is an also important short essays or short notes in our university exam. So we should learn about this zinc deficiency. In the zinc deficiency, zinc is the second most common trace element in the body after iron. And it is an essential micronutrient with a diverse but critical physiological role, being part of more than 200 enzymatic reactions. And what are the functions of the zinc? The protein and enzyme synthesis. Then, so these are the functions of the zinc. That is an enzymatic reactions. The zinc is involved in the many enzymatic reactions. So the sources of the zinc are liver, cereals, nuts, and grapes. And the deficiency is found in the protein energy malnutrition, child hepatitis, and acrodermatitis enteropathica. And the that is a deficiency which is found in the protein energy malnutrition. Also, the chronic diarrhea patients also there will be zinc deficiency will be there, and that is manifested as acrodermatitis, enteropathica, and hepatitis. And the clinical features which include growth failure, that is physical growth failure is the most important clinical feature. And then we have the anorexia, anemia, hypochromic anemia, alopecia, hypopigmented hair, dermatitis, and diarrhea. And deficiency associated with the malnutrition and the total parental nutrition, acrodermatitis enteropathica, have a genetic defect, that is genetic defect for the transporter protein CYP4, and the investigation zinc level in the higher reduced to 60 to 150 microgram per deciliter, and the treatment is we have to supplement the 1 to 2 milligram per kilogram per day, maximum up to 150 milligram. Requirement is 5 to 50 milligram per day. During the diarrhea, we have to supplement extra, that is 10 milligram per day if less than 6 months, and 20 milligram per day if greater than 6 months for 2 weeks. This acrodermatitis, and also we have delayed sexual maturation of the hypogonadism is also a prominent feature of the zinc deficiency in the adolescent child. And other features like anemia, anorexia, diarrhea, alopecia, dermatitis, impaired immune function, poor wound healing, and skeletal abnormalities, which are the features of the zinc deficiency. So then, acrodermatitis enteropathica is an autosomal recessive disorder of the severe zinc deficiency that is caused by impaired intestinal absorption of the zinc due to the defect in the intestinal zinc transporter protein, that is CYP4. Set IP4 transporter protein, there will be defect in the intestinal zinc transport protein CYP4 that results in the acrodermatitis enteropathica due to defective intestinal absorption of zinc, which presents in the early infancy with the vesicular bolus, dry, scaly, or exumated skin lesions, chiefly in the periorifice, that is around the mouth and perineum, and also around the buttocks and acral areas. And the alopecia and eye changes such as conjunctivitis, blepharitis, and photophobia, which may also be present in the case of zinc deficiency. And that is all about the zinc deficiency. Okay. Then we have the iodine. This is also most important uh, mineral in our body. The function of the iodine is an important component for the formation of thyroid hormones, triiodothyronine and tetraiodothyronine T4. Thyroid hormone which plays an important role in the body growth and brain development of the child. So if there is any deficiency that impairs the body growth of the child and brain development, that will result in the mental retardation of the child. And the sources of the iodine are the sea water and seafood or sea plants are the good sources for the iodine, and which is deficient in the soil, the mountainous regions. Hence, goiter is endemic in the Himalayan areas. That is enlargement of the thyroid gland is called goiter, which is endemic in the Himalayan areas. And the recommended daily allowance for the iodine is in the 0 to 5 years of age, that is 90 microgram per day. In the 6 to 12 years of age, there will be we have to supplement 120, or the recommended daily allowance is 120 microgram per day. In the adults and adolescents, it is 150 microgram per day. These are the recommended daily allowance for the iodine. And the what are the iodine deficiency disorders? In the fetus, the iodine deficiency results in the abortions. It leads to abortions, stillbirths, congenital anomalies, and endemic retinism. And with the newborn, which results in the congenital hypothyroidism, that is a major cause of the short stature and mental retardation child, and also that will be neonatal goiter will be the. In the children and adolescents, iodine deficiency results in the goiter, that is enlargement of the thyroid gland, impaired physical and mental functions, and subclinical hypothyroidism. So these are the iodine deficiency disorders in different age groups. And the treatment of the iodine deficiency, which include the prevention by using iodine fortified salt, target iodine content as per the National Iodine Deficiency Disease Control Program, which is 30 and 50 ppm at manufacturing and distribution level respectively. Iodine deficiency now very rare. It is also treated best by the nutritional supplementation through the oral iodine formulation. That is Lugol's iodine was used in the past. So these are all about the some of the important vitamins. That is vitamin D and this deficiency disorder rickets. That is both nutritional rickets and non-nutritional rickets are there. And we also completed the niacin deficiency. Then we completed about the iodine deficiency and also the zinc deficiency disorder, sacrodermatitis enteropathica, that is an autosomal recessive disorder caused by the defective transporter protein CYP4. So thank you everyone.